Hi, and welcome to the Breastfeeding Medicine Podcast. I'm your co-host, Dr. Ann Eglash. I'm a clinical professor in the Department of Family Medicine at the University of Wisconsin School of Medicine and Public Health and a board-certified lactation consultant. This podcast is produced by the Institute for the Advancement of Breastfeeding and Lactation Education and is co-sponsored by the Academy of Breastfeeding Medicine. Hey everyone, welcome back to the Breastfeeding Medicine Podcast. I have a special guest today, Dr. Eliza Hayes Bakken, who informally goes by her middle name, Hayes. And Dr. Hayes is a general pediatrician and board-certified lactation consultant. She is an expert work group member for the American Academy of Pediatrics Value in Inpatient Medical QI Collaborative called Project Light. I love the name of that, which is working to improve evidence-based care for newborns with jaundice through the implementation of the new American Academy of Pediatric Hyperbilirubinemia clinical practice guidelines. And she cares for breastfeeding dyads in the clinic and on the inpatient postpartum unit at OHSU, which is Oregon.
Oregon.
I was thinking about, Oregon Health
and Sciences University.
Sorry. Yeah.
Oh, good. It's a common one.
UW, University of Wisconsin, University of Washington. We're always going to who's the real UW. And so I think this is so interesting that this collaborative really tries to implement, like all these organizations can make guidelines, but then how do you implement? And I love this idea for so many other things, especially in breastfeeding medicine. So yeah, let's talk about the guideline. Thanks for joining me. This protocol covers the management of hyperbilirubinemia, and what's the age cutoff? Can we use this protocol for preemies?
So the nice thing is that we can use it down to 35 weeks, but before 35 weeks, there isn't a ton of great evidence out there. There are some guidelines that neonatal intensive care units use, but this guideline is focused on the care of preterm infants, but just start at 35 weeks and above. So our kind of late preterm infants and term infants that we're caring for, usually outside of ICU settings, although sometimes there as well.
Got it. So, I'm old. I was trained in the 1980s, and we used to just eyeball infants. And then if they looked kind of yellow, we would do a test. And we did a lot of Billy Lights back in the late 80s, early 90s, mid 90s. And then in 2004, I guess there were swings in the 1990s of don't worry about it. And, we heard this term vigintiphobia, which is fear of bilirubinemia, and don't worry about it. It's not pathologic. And we don't see that much kernicterus anyway. And then the 2004 guidelines came out, and they said to screen every baby. And I think that's probably been pretty well implemented. And so, what has that been a good thing? And does this policy continue to recommend routine screening?
Yes. So, I think that this is a really interesting area, and it's really exciting to kind of dig into the data and really understand the tension that we're facing in caring for babies with hyperbilirubinemia, so high bilirubin levels. Some of that shift that you're discussing is really because a lot of the hyperbilirubinemia that led to kernicterus, or basically the chronic bilirubin encephalopathy, where the bilirubin crosses that blood-brain barrier and leads to really severe outcomes. So these are the babies that develop basically findings that look like cerebral palsy. They can have intellectual disability, they can have hearing loss. So these are really terrible outcomes. And, in the end, when we look at kernicterus, we see that kernicterus is preventable. And so we really want to make it a never event as much as possible. So that's the one side. And I think it's really important to know how terrible kernicterus is and to do everything we can to be finding the babies at highest risk, to be treating them appropriately to avoid those outcomes. On the other side, the tension that we're dealing with is that really the kernicterus that was seen and was so scary when bilirubin lights were developed, when double volume exchange transfusions to avoid kernicterus started to happen, was really in the 50s and 60s. And a lot of that was related to the RH incompatibility, the RH disease that caused really brisk hemolysis. And so now we're able to give gestating parents RhoGAM and prevent that for the most part. And so that's really exciting, and it really changed kind of the landscape of hyperbilirubinemia. So that's that tension you feel in the guidelines. And I think we've really gone on to say, okay, if we're not dealing with RH disease, then when we look at babies who don't have RH disease but still have high bilirubin levels, what are the different subpopulations in that group of infants? And how do we start to really understand who's most at risk and the most evidence-based strategies to prevent kernicterus in those babies?
I see. So getting back to what you said about prevention during pregnancy, there is sort of a section on that. Can you talk about that?
For sure. So, the blood group incompatibility and RH incompatibility are definitely important things that we should be looking for. So, basically that section is talking about the importance that, when somebody is pregnant, we know their blood type, we're screening for potential antibody positivity in them, so that we can be proactive in the care of that baby. And so whether that's a mother that has, a random antibody like anti-E, these other minor blood groups, we can then screen the baby for that, whether that antibody passed to the baby, and whether it's causing hemolysis in the baby after they're born. Certainly for mothers who are RH negative, we need to be using RhoGAM for those kind of standard protocols, and then ensuring that they get the post-birth dose if that baby is RH positive, to prevent complications in future pregnancies. And then even with the piece around, so mothers who have O blood type, there is this possibility of what we call ABO incompatibility, leading to hemolytic disease of the newborn. So that's where the mother's developed antibodies against the baby's A or B blood groups that pass, and can cause hemolysis in that baby as well. So it's really, we start to see this shift to focus a little bit more on in that piece of the prenatal workup, looking and being proactive for babies who would be at higher risk for hemolysis.
I saw there was a pretty nice algorithm in the protocol on what to do, like if the mom is positive or negative for antibodies. So that was really great. And then, so I want to talk about this other issue regarding like those who are at higher risk for kernicterus. But first, I just want to talk about breastfeeding, because this is the Breastfeeding Medicine podcast. And we have talked so much about breastfeeding jaundice versus lack of breastfeeding jaundice, or breast milk jaundice, lack of breastfeeding jaundice and breast milk jaundice. Do you want to talk about that?
Yes, absolutely. I think that was like my, as a lactation consultant and, somebody who practiced breastfeeding medicine, I was so excited that we got away from kind of indicting breast milk and breastfeeding a bit, because I think that it made it seem, and when you say to a family, like your baby has breastfeeding jaundice or breast milk jaundice, then they immediately jump to like, I am doing something to hurt my baby. And that's the last thing that any parent wants to do. And so I'm so thankful that the guidelines have really moved away from those terms. And so in talking about what I learned when I was in training as breastfeeding jaundice, which as you said is really lack of breastfeeding jaundice, they are now calling this entity suboptimal intake jaundice. And I think that's important for two reasons. It really calls to us who, help dyads breastfeed to really focus on the importance of getting good feedings going in those first few days and weeks. But also, I think it also calls to the fact that any baby can have suboptimal intake. And so that we have to also be aware of this in babies who maybe aren't going to the breast, but also aren't formula feeding well or aren't taking donor milk well if they're, unable to go to the breast. So the bottom line is we need to make sure that infants are getting what they need in those first few days, that we're getting things off to a good start. and that they're not having excessive weight loss and signs of dehydration. And they really focus on that. So the focus is, really, is this baby showing us clinically that they are not getting enough to eat by not having output, by looking dehydrated on exam, rather than indicting the breastfeeding.
Yeah, although there is a comment about how breastfed children, infants, are likely to have a higher bilirubin in the first month. They talk about 34% of breastfed infants at 28 days of age will have a transcutaneous bili of at least 5, and 9% are over 10, and 1% over 12.9. So I think they're always, I think we see it clinically too, right? That babies who are breastfed are probably going to linger a little bit longer with their physiologic jaundice than those who are formula fed.
And I think what you said there is what's so important, is that that's what we're talking about as physiologic jaundice. And I think that we really need to start, just as there was that whole, you brought up vagentophobia. It's one of my favorite things. If you haven't had the joy of reading the article entitled Vagentophobia, which is a play between a med student it's a resident and 2 attendings, where he's like, why are we scared of the number 20? These babies seem okay to me. It's hilarious. But if you hadn't had the joy of reading that, I highly recommend it. But, it's really that we get focused on these numbers and believing that a specific number is necessarily bad. And really, I think maybe we're kind of moving to Trentophobia, fear of the 30s. But in general, I think the point is that babies who are well underneath those numbers that we know lead to an increased risk of kernicterus, that it doesn't mean that each successful step up is somehow bad, or being at 10 or 15 or, is for a couple of weeks is necessarily bad. There are different theories around it may actually even have some neuroprotective effects and other things. It's physiologic. So we need to be focused on the situations where the hyperbilirubinemia is pathologic. And that's both the number the child reaches and probably some other factors as well, some of which we know, which are under that neurotoxicity risk factor categories. And some may still be out there to be determined, because this, when we look at the infants who get kernicterus, it's a really heterogeneous group from the group of infants that we're treating and monitoring for hyperbilirubinemia. So I think
maybe this slightly elevated bili that we see in breastfed babies versus non-breastfed babies, maybe we need to reframe it, just like we used to say delayed cord clamping. Now we say normal cord clamping, and it's early cord clamping. So now we need to say lack of physiologic jaundice at 2 weeks versus
perhaps. I mean, I think the bottom line is that, when we look at, there's great guidance in there about how we can work up those infants to make sure that we're not missing something else. But in general, there's a normalization of the fact that those bilirubin levels remain elevated for a longer period of time. And we need to, again, look for that needle in a haystack infant that may have something else going on that we need to detect to get them the right treatment. But usually those aren't the infants that we're worried are going to go on to develop kernicterus.
Got it. Okay. So let's talk about that higher risk group, the group that's more at risk for jaundice, for kernicterus. And then also maybe within that, you can talk about hemolysis, because there's an emphasis on hemolysis, and maybe those with hemolysis have a higher risk of kernicterus as well.
Yes. So, I think that, yes, there aren't really big changes when we look at the neurotoxicity risk factors. The main change that happened was there were some spelled out different indicators, clinical indicators of infants that are sick, that are clinically unstable. And those are kind of grouped now into this category of clinical instability in the previous 24 hours. What all of these risk factors are getting to is that there seems to be situations where that blood-brain barrier is more porous, where it's more likely to allow the bilirubin to get through. And so where we can see infants who end up at the same very, very high bilirubin levels in the 30s, some will go on to develop the clinical diagnosis of chronic bilirubin encephalopathy or kernicterus, and some won't. And what is that? what is that puzzle there? And so that's what those risk factors are getting to for the most part. So they're getting to this more porous blood-brain barrier. The next category is that category of hemolysis. And so if there's hemolysis going on, it's a little bit heterogeneous from the other categories. So a lot of the other things on that category are getting to, is there a reason why the bilirubin in this baby may be more likely to cross the blood-brain barrier? In the hemolysis category, we're really getting to the fact that hemolysis can be unpredictable. And so these babies can kind of have an increase in hemolysis, a decrease in hemolysis, and they don't follow that more standard pattern that is that as intake increases and as output increases, that they're able to get rid of the bilirubin. And so for a baby with hemolysis, if the production of bilirubin increases, even if we increase their output of that bilirubin, we may not be in balance. And so the goal is to make sure they're staying much farther away from those exchange transfusion or levels at which we know could potentially cause kernicterus in the 30s because of that unpredictability in kind of the rate of turnover of their red cells and the rate that they're producing bilirubin.
Interesting. Yeah, that's a concept that I don't think we really discussed in the past. So what tool do you recommend that we use for phototherapy guidelines?
Yeah, I think the cool thing is that there are lots of different tools out there. I think everybody has a favorite. There are definitely different options. The ones that I think a lot of people use, and I don't want to leave anyone out, who's made their own, but the ones I hear most used are PD Tools and Billy Tool, and they have now both gone on to update their guidance. So if you were using them before, you may already have kind of moved over. What happened is that basically the mathematics behind the curves, the new curves that were developed, is basically plugged into those tools as a calculator so that you can put in the gestational weeks for the infant that you're seeing. You can put in how old they are and whether they have any of those neurotoxicity risk factors. And the tool will tell you, okay, these are your next steps. It'll even go to the point of if the measurement that you got was a transcutaneous bilirubin, that it would recommend getting a serum bilirubin. It also will tell you if they're in this new area, which is 2 milligrams per deciliter below the exchange transfusion threshold, where escalation of care, kind of more steps in that baby's care are recommended. And so it kind of goes through all of that for you in both tools. It just is presented a little bit differently. And so I encourage people to check those out. I know a lot of health systems across the United States also use Epic as their electronic medical record. Epic does now have these new calculators available to be used by institutions. So if your institution is using calculators in Epic already or not, that's something to talk to your IT teams about whether that might be possible for you.
Sounds good. Yeah. So there also is a section talking about the concern regarding jaundice in the first 24 hours, and that one should be thinking differently if there's visible jaundice at that time.
Yes, and I think that's another clue pointing to when we sit down and talk with the experts that created these guidelines and the discussions that they had over a really long period of time. We've all been waiting for these guidelines. They're supposed to be created every 10 years. And so those guidelines were from 2004. So, we've been waiting for these a long time. So there's been a lot of clinical discussion happening and a lot of exciting research that's come out in that period of time that's really pointing to the fact that hemolysis is a clinical entity that is much more likely to lead to higher bilirubin levels and to the development of kernicterus. Where do we see that? We see that when we look at, for example, the studies that have looked at the Northern California Kaiser system was used as kind of a closed system to kind of have good follow-up for infants. And they really found that of the 4 infants who had bilirubins over 30, who had clinically developed findings that were consistent with chronic bilirubin encephalopathy, 3 of them had decreased G6PD activity, and 1 of them didn't have their G6PD activity measured. There were other infants in that sample who had those high bilirubin levels and did not develop kernicterus. And so it's clear that, trying to find that needle in a haystack of G6PD deficiency infants, making sure we're looking for ABO incompatibility as well is an important step because of what we were talking about, that unpredictability in that rate of rise of the bilirubin levels. And so infants who already have elevated bilirubins in the first 24 hours are much more likely to be your needle in a haystack. And so that is where it's really helpful. There's a couple of clues in the guidelines that will kind of clue us into having a higher index of suspicion. And one is that really early jaundice. And then the next is the rate of rise. So if you're able to get 2 measurements, that it can really clue you in to a baby whose bilirubin is rising much more quickly than we would expect.
Mm-hmm. Yeah. So I was going to say that I always like to look at the rate of rise. That just a spot Billy doesn't tell you nearly as much unless it's really high in the first 24 hours. And so, what is an aggressive rate of rise or concerning rate of rise?
Yes. And so basically the guidelines say that and this is nice. I think we've all read different things, but it's in the guidelines now, which is great. They basically define a rapid rate of increase as greater than 0.3 milligrams per deciliter per hour in the first 24 hours, or 0.2 milligrams per deciliter per hour thereafter. And so you can get your 2 measurements and use either a transcutaneous or serum measurements to look at that rate of rise and get some inclination about whether this is a baby that you should have a higher index of suspicion about hemolysis for. And so, that's helpful, I think, as pointing us into what we should be looking for sure.
Yeah, I would agree. Yeah, absolutely. Yeah, trying to assess when to follow up whoever. It's that I think the guidance is really helpful in looking at that rate of rise. And then also, it seems like there's a lot of information about transcutaneous versus serum billies. And I get the impression that the protocol is pretty supportive of those transcutaneous billies.
I know. I think it makes me look and get a little nervous. I think it's a good time to be in the transcutaneous bilirubin market. But, and so, I don't want to add to just the commercialization of all these things, but, the evidence is strong when we look to studies that as clinicians, we are really pretty darn good at knowing if there's any jaundice present, but we are pretty darn bad when we estimate what number that jaundice is at. And so the bilirubin meters give us kind of a confidence interval, so plus or minus 3 points. And that is really helpful and better than we as human beings and clinicians perform in studies when we're comparing ourselves. And so it's kind of plus or minus 6. I've even seen, kind of error ranges in the 15, 16 level for some clinicians. So, I think it's really important to make sure that when we do those measurements, we're doing it in a baby who appears jaundiced. So we're like, this baby is jaundiced, that we are not anchoring to, it's just in the face, or we only see to the top of the chest, that we are getting that measurement. The other piece around that is the fact that in the United States, the highest rates of G6PD deficiency are going to be seen in Black infants, so as high as 10 to 14%. And so, doesn't mean that every infant with G6PD deficiency is going to have hyperbilirubinemia. But the fact is that I think there's evidence to suggest that we may not be as good at detecting visually jaundice in infants with more melanin in their skin. And so we need to be sensitive to this and make sure that we're not introducing more bias and inequity in the ways that we're treating infants.
Right. Yeah, I've oftentimes wondered why the G6PD is not part of newborn screening.
Yeah. I mean, it makes me so nervous. So as a clinician out there, it's something that I check not super infrequently. And, I think when we look at those infants that did go on to develop kernicterus, I won't be surprised that if there's another guideline coming as these continue to be updated and we continue to learn more, that we start to zero in more and more on the importance of G6PD deficiency, especially because to some extent we know that ABO incompatibility, that hemolytic disease of the newborn, has some predictability where hemolysis is more brisk and it kind of decreases. But G6PD deficiency is kind of the acute hemolytic events related to it can be really unpredictable. And it has been shown to relate to, for example, a mother or a lactating parent, eating foods that like fava beans that might cause an acute hemolytic event. But also sometimes there can be acute hemolysis without a really clear precipitating cause. And so as a clinician, that uncertainty makes me super nervous.
Yeah, it does make me nervous. And I wonder if this is, just a health inequity thing, like, should we be screening parents when, the parents when an individual is pregnant for the risk, if they're carrying any genetic, marker for it, or if they have it.
And especially because I think that that's really important. I mean, we know this is X-linked. And so, but the important thing to know is I've actually heard folks say, I'm in an academic setting, so, residents saying, oh, but why are we looking for G6PD in this female infant? And it's because actually with lionization, so kind of the X inactivation being inconsistent across those X chromosomes, we can see decreased G6PD activity in female infants. And so, we need to be really cautious about that and know, those just even knowing the X chromosomes that are being passed even from one parent is potentially an important clue. So
yeah, it seems like I don't think it's a health inequity thing. And also, I think it's also a sign that we have that breastfeeding has kind of we're in this age of increased breastfeeding rates, but then policies have not kept up. Like the whole policy, like, oh, back to birth weight at 2 weeks. Well, that was based on formula feeding, right? And then, and so then if you think, knowing that if a baby's who may have G6PD deficiency is being breastfed, they have a much higher risk if they're breastfed than if they're not breastfed, I would think, because of the risk of the different foods and medications that they may be exposed to during breastfeeding. But because those weren't issues before in largely formula-fed babies, and knowing that the African-American population has breastfed less, and we still see that health inequity, I feel like we need to pay more attention to this. Yes.
Yeah, I 100% agree. And I mean, I think even when you look at the new curve, so one of the main things in the new guidelines is these new curves. We all I carried around, I think I was pre Billy tool, but carried around, like I still have my little like paper 2004 guideline nomograms. And when we look, what we really see is that those guidelines really were focused on this much more smoother idea of bilirubin being a problem. And the new guidelines, there's not a lot of change in bilirubins that cause concern in the first kind of 24, even to 48 hours. But beyond that, those cutoffs where we would do phototherapy for an older infant are much higher, which is also when we see suboptimal intake jaundice at the like 2, 3, 4 day kind of period of time. And so I think, when the evidence was clear, a lot of that comes from studies that looked at the number needed to treat. So they basically looked at infants, by their gestational age, and they said, how many infants do we need to treat at different hours of life in order to prevent one from going over exchange transfusions? And the numbers were hugely different. We're talking about like preterm infants that were in the first 24 hours. It's like 10 to 15 infants need to be treated to prevent one from needing an exchange transfusion. But when we look at term infants at 3 days and beyond, it was like 3,000, right? So, it really is, again, these clues pointing back to we need to address suboptimal intake. And I'm not encouraging anybody to ignore it, to ignore a baby who's 3 or 4 days old and really jaundiced with suboptimal intake. we definitely need to treat that. But the guidance really showing that really there is this heterogeneity, and those infants that are earlier, the infants with hemolysis, we should really be looking for those infants and making sure that we're being really aggressive in how we manage them.
Interesting. That's great. Yeah. So I want to talk about, let's say that bilirubin is high, and I just want to give you a hypothetical case. So let's say that you're seeing a baby who's breastfeeding well, gaining just fine, and the bilirubin is still fairly high. Let's say it was 16 on day 5, 16.3 on day 6, 16.5 on day 7. So it's just going up a teeny bit. And then on day 8, it's 16. So you think, coming down. Okay, we're good. And so this is a real case. So that I saw in the breastfeeding medicine clinic, and the baby continues to overall feed fine, gaining an ounce a day, 30 grams a day. And now at 20 days, the baby looked kind of jaundiced. And so I did a Billy, and it's 17. And this baby overall continues to feed well. So what would be the workup at that point?
Absolutely. I feel like I'm dealing with this so much. This is like my world. I have lots of cases like this. And I think we're all like, how do we deal with this? I mean, I think first off to say that the initial management in those first couple of days looks appropriate to me, right? We have a slow rate of rise in a baby who's, initiating good feedings, having some good weight gain. And then to see that the bilirubin is decreasing is reassuring. But now we're out at day 20, and we're kind of in a different zone. And so what we're looking for is a little heterogeneous at this point. We want to, I think the first check is, depending on this infant's gestational age, the phototherapy thresholds are probably going to be pretty darn high, for an infant this old. But the new nomogram guidelines do go out to 2 weeks, and you can kind of extrapolate beyond that probably. We're probably at 3 weeks of life not talking about a baby who's going to need phototherapy, but let's say this happened in that first 2-week period. The first question is this baby getting close to a phototherapy threshold? And the new guidelines say if they're getting close, then 2 points or so, you can consider outpatient phototherapy. So you could consider sending them home with a Billy blanket to kind of bring that level down. But that you should also be thinking about in that infant whether there's something else causing it. And that's where we are with this 3-week-old now. We need to say, what we're looking for now is not necessarily preventing kernicterus as much as, is there something else that's leading to hyperbilirubinemia that we need to detect and get to the bottom of to make sure that this infant leads a healthy life. What are the things on that list? They're numerous, and the guidelines actually really go through a really nice differential diagnosis. But the first step is to make sure that there isn't a direct component to that bilirubin. So if that's basically when we send the baby to the lab and we get a total bilirubin, which is what you're reporting, that we can ask them to fractionate that and tell us what part of that is that direct bilirubin. And that's really important because if that's elevated, it can give us clues and point to the fact that we need to think about how the liver is handling the bilirubin and whether the liver is functioning appropriately. It can point to things that are going on with the liver. I've taken care of a baby with bile acid salt deficiency that had really severe hyperbilirubinemia, and that was undetected for a while. I think a lot of people also think about like biliary atresia and those kinds of things that really do need to be detected and treated so we can prevent these infants from going into liver failure. Again, it's a needle in a haystack, but it's not a big deal if you're going to get another level to go ahead and fractionate it. And so if it hasn't been fractionated recently, I think that's a first step. The next thing is to think about the other things in that differential diagnosis. So, for example, hypothyroidism is on there. That's really important to detect. Hopefully that's on your newborn screen. I think it's pretty universal. But looking back, do you know that newborn screen is back and it's normal? Unfortunately, we see, if there's uneven saturation and they couldn't run it, or, these kind of things that happen to really just dot that I and cross that T. Also, sometimes when a newborn screen is not done as a two-part screen, there are a few cases that can be missed. So it's not a bad idea, especially if there's any other clues that something else may be going on, to check a thyroid level as well and make sure that that looks okay. And then the guidance kind of goes through those other things. So things like Gilbert pop up and other things, that I think are a little bit more. So what is my usual workup? I usually would make sure I've gotten a direct bilirubin. With that total going up, I would make sure that I'm moving to a serum level so that I know, because that increase is still within the rate of error and you're kind of above where transcutaneous bilirubin, above 15, it's less reliable. So I'd make sure that I'm checking serum levels and getting a direct. Sometimes then we'll also think about ongoing hemolysis or G6PD. So getting a CBC and seeing, what does the hemoglobin look like? Is there reticulocyte count? Get a G6PD activity as well, especially if there's any suggestive family history. But then starting to think about kind of trending it, seeing that baby back in a week or so, trending that bilirubin, what is it doing? And then kind of escalating my interventions and my workup if I see that it's not coming down at all or continuing to rise.
Right. So that's actually, so in terms of breast milk jaundice, what we, say, just the classic breast milk jaundice that leads to a bilirubin that sort of gradually trends down. From my experience, sometimes it's not really undetectable until, in terms of visually undetectable, until they're like 3 to 4 months sometimes. Mm-hmm. But that's kind of high for for breastfeeding jaundice, right? For, at 17 at 3 weeks, I would think it would be a little lower, like maybe 12 to 15.
Yeah, I think a lot of us who've done this will say we've seen those cases. And when we look, there is a percent of the babies who were in those higher number ranges when they looked at the study. It's small, right? So we're talking about, they're a significant standard deviation below that mean. And so or above that mean. So we need to be thinking about them. And so I think, have I seen what we classically call breast milk jaundice lead to bilirubins in those high teens? I have. Where we've done additional workup, nothing has come up. Unfortunately, I think the other thing that we've all seen is where people would recommend then switching to formula, or the family gets anxious and they switch to formula, and that does bring the bilirubin down. And so I think that's where it's really important that we're doing good counseling, that we're being careful with our words, and how we talk about this, to say, the bilirubin itself is not a problem. Your baby is safe at this level of bilirubin. I just need to make sure that it's not giving me a little clue that something else may be going on. And so I need to go looking for those other things that might be going on that might change, how we treat your baby. But your breast milk alone causing an increased bilirubin is not a danger to your baby. I'm looking for other things. And I think being really clear about that, because I had baby that was like right around 20 and the mom just got so stressed. She saw lots of different people. She switched to formula and it like came down in 2 days to like 12. And it's like, okay, yes, now we know, but it's in the end, we did already know, because we'd done all the workup, everything was reassuring. And, there was nothing to say that being right around 20 was actually doing any harm to your baby.
Right. Absolutely. Yeah. Let's talk about Billy Lights. So, I think that, when in the 1980s, I had my 2 kids in 1990 and 1992, and they had a really severe ABO incompatibility. So they were both jaundiced at 8 hours of age, and we went home with the light box. And in Los Angeles, there actually was a team of nurses who had a company, which was just a home bilirubin company. And the babies sat in a box, and they came and monitored every day and checked on breastfeeding and things like that. But it was overhead lights. It wasn't a simple billy blanket. And I think back to that, and I think, I don't know how safe that was. And so considering it was overhead and we had to keep the mask on, and, it was hard to sleep because you're worried the kid's going to suffocate, with the mask going over their nose. And So yeah, what does that look like now for people, for home Billy,
what the different options are. And so, I think the first thing is, again, these thresholds have increased. And so the goal, ideally, we're not providing as much phototherapy. And, we may be able, these babies that were kind of right at the threshold. The other thing we saw is that the old guidelines weren't incredibly clear in making a distinction between babies who were, for example, 35 weeks exactly gestationally and babies who were 37 and 6. Some people kind of added a few points, but not everyone did. And so I think there was some significant overtreatment going on there. But the new guidelines point to the fact that we can basically, if babies are at these phototherapy thresholds, we definitely need to, oh my goodness, there goes my dogs. My husband just went outside. He's trying to move the garbage.
No, I can't even hear it. No problem.
So the new thresholds basically are higher, and so hopefully we're providing less. But if an infant is at that new threshold, we really need to be doing the intensive phototherapy that I think it's interesting that sometimes may be done at home, but from what I've seen, this is like exclusively done in the hospital. The new guidelines are very specific about what irradiance, kind of we should be looking for from our lights to make sure that they're providing that intensive phototherapy. We went back as an institution and it was no different than what we were doing. It's just much more specific. But there is now this guidance about, could we do some home phototherapy for these babies that are kind of on the bubble? And the guidance says, yes, if babies are overall low risk. So older, this is babies that have gone home from the hospital, that are not preterm, that, are feeding effectively, that whose bilirubins are kind of in that 2 points below the phototherapy threshold range, that we can consider doing home phototherapy for those babies. And that's just with a Billy blanket at home that they can sleep on and be cuddled with, et cetera. But that we need to make sure that we're able to get those Billy lights started without delay, that we're able to follow up those babies, get us another serum bilirubin within 24 hours and make sure that things are improving and that they don't need to actually go on to have the intensive phototherapy. So there is good guidance in there about that and about, when to consider that and who they believe are the right candidates for that approach as well. We were talking as a group, and I think even in our collaborative, that sometimes, unfortunately, I think where the expert work group felt the babies were the lowest risk, these were not necessarily the babies who we find have that prolonged. So what you're talking about, ABO incompatibility, they actually would say hemolysis is not a baby that you could do home phototherapy on because you need to be monitoring much more closely. And so, that's kind of, I'm not sure that the home phototherapy approach is going to be there for oftentimes the kids we feel like we need it for, and would like to get those families home. So
right. So I didn't see anything in the guideline about continuous versus intermittent phototherapy. Do you know much about that and whether there was intention to leave it out or yeah?
There is a little bit in there about talking about kind of trying to keep the baby under the lights as much as possible. And so I think the way I read the guidelines, it really is encouraging kind of continuous phototherapy with the breaks for feeding. And so I'm not sure if that's what you're talking about, intermittent, but when an infant is not feeding, that they should be under the lights, which is really hard for families. I think thinking about as institutions too, how do we make sure infants are admitted that we're doing things that are more family centric? These, in my current institution, these infants are managed in kind of the postpartum unit. Families are together. The parent is taking the infant in and out of the phototherapy, versus in a previous institution, infants were readmitted to the neonatal intensive care unit. Families weren't able to stay together. And so really encouraging and advocating for practices that are more family centric, where we can provide this phototherapy but empower parents to be part of the team and be there at the bedside providing all of that reassurance and snuggling and patting and whatever else they need.
So. These studies that actually came out showing that just giving bouts of phototherapy intermittently worked just as well as continuous, with the theory that it takes several hours for the bilirubin to sort of like get to the surface of the skin. And then once they're zapped, that just takes a couple minutes for that bilirubin to be converted. And so, I'll send you those studies. I thought they were interesting.
That'd be great. I think the one thing I wonder about that though too is, it'd be interesting to look at like what were their outcomes, because to some extent, I think a lot of the intervention that a lot of us were trying to do different things because we realized that we were really over treating infants. Mm-hmm. And so we were doing a lot of phototherapy for infants who were probably never going to get near exchange transfusion levels. Mm-hmm. If anybody had that admission where in the clinical setting, they were above phototherapy and they come in, they're already sliding down. The other thing we know is that when they looked at the implementation of the 2004 guidelines, there was a ton of sub-threshold phototherapy that was happening. Mm-hmm. People were basically saying, okay, they're within 1, they're within 2, they're within 3, let's start the phototherapy to try to still discharge them on time. Mm-hmm. And, I think there's been a lot of research to say, is there a risk of phototherapy? And most of it has suggested no, but the research around the increased risk of epilepsy, of seizure disorders, is kind of concerning. And it's pretty consistently found that there's a small but present increased risk of seizures after treatment with phototherapy. What is the pathophysiology there? I think there are theories, but nothing's clearly proven. But I think that it just points to the fact that we think of phototherapy as being kind of innocuous, and maybe we shouldn't. And so I'm really advocating, in our collaborative, we're advocating to really do away with sub-threshold phototherapy, several points away from the phototherapy cutoffs with the new guidelines, which are higher, especially for infants that are lower risk. And really move to focus on doing phototherapy, doing it intensively for ideally a shorter period of time for the infants who need it, and getting them back out of the hospital. The guidance also points to the fact that the goal is to get the baby drive their level significantly below the phototherapy threshold where they were when the lights were initiated, which also points to driving it much lower for infants who are having, high levels of bilirubin in those first couple of days, where those threshold levels are much lower, versus not needing to get it quite so low in the infants who are older, right?
Yeah. Yeah. And so that maybe segues into the conversation about rebound. And so that was kind of new. That wasn't talked about in 2004, I think.
Right. And so there have been, different rebound calculators and different things that have been out there. Various people have done different things. And I think, it was so interesting, as a resident myself, but then even in my residence, like, where are you on the rebound spectrum when they come on service with you? Like, what are we doing on this service? Because it was clear that there was a lot of heterogeneity in how we were doing this. And so the goal of the new guidelines is to really focus. A rebound level is basically where we keep the infant, in the hospital setting. We turn off the lights and we measure the bilirubin around the time we're getting ready to turn off those lights. And then we measure it several hours later to see how fast it's increasing now the lights have been turned off. That means keeping the family in the hospital. It means, and it sounds great, but I don't know if your institutions are like mine, but it's like, ask for the blood draw, an hour later they come out and it goes to the lab, and sometimes there's processing issues. And so it can be a long process. Yeah. And I think oftentimes you end up in this in-between category, but they are really pretty specific about who they think needs a rebound level drawn. And it's, again, those infants that are higher risk. It's the infants that have hemolysis going on, the infants who needed phototherapy at earlier ages. And so definitely encourage people to go through those tables and guide on the guidelines and kind of look through and align their clinical practices so that we can decrease where we're getting rebound bilirubins in infants who probably really don't need them and can be followed up in the outpatient setting.
Great. Yeah, this is such a good review. Thank you so much. I was talking to some of the pediatricians in our system, and they said, yeah, these new guidelines are so long and there's so much, and I kind of feel like it validates my intuitive management of hyperbilirubinemia?
For sure, definitely. I think a lot of us, so in the Pacific Northwest, so in Northern California, and then here in Portland, Oregon, we'd actually implemented other guidelines with higher thresholds before. And that was part of the work I had done called the Northern California Neonatal Consortium Guidelines that looked a lot of the research coming out. And so I was able to get comfortable with it much sooner, but I think there was a lot of kind of angst that we felt like they just didn't feel like they were quite right, that they were hitting the mark. And so I'm excited. I think this moves us a ton closer. I think we need to be clear that the level of evidence for these guidelines, for these key action statements, is still low. And so we need to be flexible and realize that this is an evolving field and that things are likely to change again with subsequent relooks. But I think there's really clues here in how we kind of hone our clinical instincts and who we should be worried about, and giving us more guidance to kind of create more uniformity in our practice so families don't feel like they're hearing all kinds of different things. And I think that that's an important move in the right direction. And so it's been really fun to help hospital systems implement these guidelines. If you're feeling overwhelmed by the guidelines, there are great webinars and summaries out there put out by the AAP with a lot of some of my favorite people on them. And so highly recommend people lean into that and kind of check those out if they feel like they want a more in-depth look as well.
Excellent. Thank you so much for this review. I really appreciate it. And I'm so glad that we're no longer talking about starving breastfeeding babies.
Definitely. It's so important.
Well, take care, and thanks again, and hopefully we'll be in touch at some point.
For sure.
Bye.
Bye.
For questions regarding this podcast, please contact us through our website at lacted.org. We have other educational projects, including the Clinical Question of the Week, our Little Green Book of Breastfeeding Management for Physicians, and our various educational courses and conferences for physicians and other breastfeeding supporters. If you want to see what we look like, check out our Breastfeeding Medicine podcast Facebook page, where you can post any questions or comments about our podcasts. Thanks for listening, and we'll be back with you in about 4 weeks.